You all know that is the man behind almost all research on biologics, both in basic science and clinical studies. So we are very privileged and honored to have him with us today. Thank you very much, Professor Bachert. The stage is yours.
Thank you so much for the kind invitation. Just to mention shortly that we also developed the reboot surgery, but my topic today is biologics for chronic rhinosinusitis with nasal polyps, and I hope to get it done in 20 minutes. So what is meant by biologics or biologicals, some people say? This is about approaching specific molecules such as interleukin-5, IgE, interleukin-4 or 13 in the nasal polyps. And what we need to do, or what we use for those approaches, is monoclonal antibodies that have been developed specifically against this target. So it's a totally different approach from corticosteroids, where we are very broad. And of course, we know very well about the possible side effects, which we actually want to avoid. Biologics or biologicals are much better tolerable than corticosteroids. And we always have to bear in mind, of course, that these are long-term treatments in those patients. First of all, my conflict of interest, you can see here, and that has just to do with the fact that I did these studies with these companies. I don't get paid extra, I just did the study. So we are talking about chronic rhinosinusitis with nasal polyps today. The symptoms are very well known. I think I don't have to talk about it. And you see specific signs, I would say, for likely type 2 and a more severe disease. Likely type 2 is 2 points. Asthma comorbidity. Asthma comorbidity in patients with nasal polyps tells you 95% it is type 2. Type 2 means eosinophils or IgE or both are involved. And if you don't have asthma comorbidity in the patient and you want to know whether that's type 2, you can look best at the blood eosinophils. Blood eosinophils above 300 also tell you with 95% that this is type 2. Of course, you cannot recognize everybody with this simple algorithm, but you will find out 85% of the patients with nasal polyps in Europe are anyway type 2, and you don't need to ask those questions in those if you can recognize them. What we always also ask is how many prior surgeries and what technique has been done. Surgery is not like surgery. And of course, systemic steroids and other treatments, what has been given so far. And very often, these patients had 2, 3, 4 surgeries already, have long time topical steroids, but also courses of systemic steroids without getting control to this disease. Now, what do we mean with type 2? And I think that's a key here in this presentation, because it is very clear. We heard it in the previous presentation about ventilation and drainage. This here is about the mucosa. I call it the mucosal concept. It is the inflammation in the mucosa. And inflammation does not only mean that we do have inflammatory cells such as eosinophils, neutrophils, T cells, but it also means that there is a memory in this mucosa. Whenever you treat this, for example, with a corticosteroid, the inflammation will persist because of the memory of this inflammation. So it's not easy to suppress this information, and we should realize that. For example, if you just reduce part of the mucosa, that might not give you the result that you want. That's why we talked about reboot in many cases, because we really want to get rid of the information in the mucosa. However, today we talk about biologics, and of course, these inflammatory mediators, such as interleukin-5, very central here, for the eosinophils, the interleukin-4 and 13, which are important for B cells, and that's what I want to say for it about it today. It's much more complex, but this is very important to remember, are Th2 cell cytokines that are released in this process of type 2 immune responses. It starts earlier, it starts at the innate lymphocyte cell level, ILC2 level, which already contributes type 2 cytokines. And it can make a sort of a self-sustaining loop in that the results, for example, the EETs, the sarcolytin crystals released from eosinophils, induce again inflammation. So it is a never-ending story. And that is exactly what we see in our patients. A lot of them have chronic disease. You see that very clearly with asthma, and you see that also in some of these patients with nasal polyp disease. So in this situation, where could you eventually interfere? Now, what I show you here is something from 2016, where we already talked about type 2 and non-type 2, because type 2 and non-type 2 really makes the difference in these patients. In terms of asthma comorbidity, type 2 has much more asthma comorbidity, up to 70%, and also in terms of recurrence. And the red here is the recurrences. So the more type 2, the more likely you will have recurrence. That's why it is very important to understand from the very beginning, is this likely type 2 or not? Because that could change your best approach. And in terms of surgery, that means complete surgery, not radical. We don't need to be radical in any way, but complete surgery. And of course, in terms of biologics, that is that this patient can be treated with a biologic. Now, in whom would we consider a biologic treatment? Because we have to understand that this is a long-term treatment and it's not inexpensive, as we all know. So we have to clearly select those patients. And these are the patients with a bilateral nasal polyp score, which I call them severe nasal polyps if they have a score of 4 or more. And at the same time, they have to present with symptoms such as loss of smell, nasal congestion, SNOT-22 increased. Of course, these patients also have undergone certain surgery, certain treatment before. And if they are eligible for biologics, they should be uncontrolled by those treatments and long-term uncontrolled. Of course, you can give an oral steroids. There's a reaction to that, but this is not long-term treatment because you cannot perform long-term oral steroid treatment. So either oral steroids or surgery have been applied before. It doesn't have to be surgery necessarily. The patient stays uncontrolled. The patient has severe chronic rhinosinusitis polyp score of 4 and is symptomatic. And in these situations, you would have the possibility to indicate type 2 biologics. Now, how do you recognize type 2? As I said before, asthma comorbidity. If there is asthma comorbidity, 94%, you have type 2 in the nasal polyp. And if that's not the case, then the eosinophils are above 300. There's also 95% you have type 2. You also can look at former surgeries because these patients often suffer from recurrent surgery. So if you find eosinophils in the former surgery specimen, then this is also enough to say this is type 2. This immune reaction is orchestrated by T cells, as I said, ILCs and T cells, but it's actually orchestrated via cytokines. And these are the targets for interventions, such as interleukin-5 is very clear connected to eosinophil migration, maturation, interleukin-4 and 13, which is very clearly related to the development of B cells, B cell switching, IgE formation, and also polarization of macrophages, for example, barrier disruption of the epithelial lining, which all is the reason why these patients have much more than normal infections, because they cannot defend themselves sufficiently against infections. Type 2 immune disease, immune suppression of type 1 actually is related to repeated infection. And here you have the surgical option, in my eyes, is a reboot approach to remove completely this mucosa. It heals within a week. New mucosa is grown from the nasal cavity into the sinuses, and that heals with great success, also long. However, there are also new and innovative possibilities, such as monoclonal antibodies. And clearly the best studied monoclonal antibody at the moment is dupilumab, which is an anti-IL-4, IL-13 antagonist, which actually means it binds to the IL-4 receptor alpha and makes the binding of IL-4 and IL-13 to this receptor impossible, which means that the signaling IL-4 and 13 is interrupted. And that, of course, has a lot of consequences on a variety of cells, not just the eosinophils, but also T cells, epithelial cells, and so on. This study was a multinational, multi-center, randomized, double-blind, placebo-controlled parallel group trial, standard of what you expect today, over 24 or 52 weeks. The difference here is, of course, 24 weeks is just to show suppression of the immune reaction. 52 weeks tries to see what is the long-term result, although meanwhile, there are a lot of patients treated over 3, 4, or 5 years. These studies always run against placebo, and everybody in the study had topical glucocorticosteroid treatment. Inclusion criteria were that the patients had systemic steroids within the last 2 years and prior surgery without control of disease, and that they were symptomatic. And here you see that these patients had, in an average, polyps since 11 years, so clearly a long-lasting disease and story. 63% had at least one surgery, had a bilateral nasal polyp score of 6, had a Lund-Mackay score of 18, so a lot of involvement of other sinuses also, had an UPSID score of 14, which is actually equivalent to anosmia, and 60% of them had also asthma comorbidity. So a really severe population of these patients, which we treated here, and the treatment results are published in The Lancet 2019, time is running, 3 years already, clearly showing that if you look at panel A, the placebo does do nothing over the time. The polyps even grow under the placebo, which we also know from clinics, of course. And with the verum treatment, dupilumab, you have a clear decrease in the polyp score of about 2 points at 24 weeks and about 2.5 score points at 52 weeks. This tells you 2 things. First, this translates into a minimalization of symptoms, like this nasal congestion, obstruction, the smell comes back. But it also tells you, when you stop the treatment after 24 weeks, that the symptoms come back slowly, not to baseline within half a year, but at least they come back. That means that we have to think about long-term strategy in these patients concerning biologic treatments. Here's the loss of smell. Loss of smell reacts very fast. The UPSID on the right side, you can see just within 2-4 weeks, you have more than 80% of the patients reacting to this drug with a regain of smell. And this is very, very impressive for the patients who sometimes 3-5 years had no smell and suddenly can smell again. And of course, they maintain this possibility of smelling over the time of the treatment. However, again, it will be lost later again if you stop treatment. There's also an effect on the lower airways in terms of FFE1 and asthma control questionnaire. Of course, many of these patients, although they were not selected on the basis of having asthma here, these are the patients with comorbid asthma. They also feel a change in the lower airways. And finally, what is impressive, of course, is that this treatment is a sort of a standalone in most of these patients. So other kinds of either systemic steroids, which we clearly want to avoid, or polyp surgeries, repeated polyp surgeries, is really reduced by a high percentage, up to between 75 and 90%, less than in the placebo arm. And that, of course, means that we guarantee, or we can guarantee for the patient a long-term treatment, which does not afford other treatments to complement this one. This is a patient we saw from 2017 to 2018, so some time ago, and you see very nicely how the nose and the sinuses cleared up fully. So at that moment in 2018, there actually were no polyps left. And you see also that it takes some time again. The sinuses, the nose is free, but the sinuses are not yet free after half a year of treatment. What about adverse events? Really very tolerable. There is a conjunctivitis in some patients with atopic dermatitis, but really not much in terms of side effects and adverse events in patients with chronic rhinosinusitis with nasal polyps. As I showed you in the beginning, there was interleukin-5 and IgE. So anti-IgE and anti-IL-5 and IL-5 receptor alpha could also be other approaches in terms of biologics. And there have been studies done. The POLYP1 and POLYP2 studies, two similar studies, looking at omalizumab and the effect on the nasal polyp score. Now, these patients are not the same, and it's not a head-to-head comparison with what we just saw with dupilumab. But here the response in nasal polyp score is in the range of minus 1.2, whereas it was minus 2 to 2.5 with dupilumab. We see clearly that anti-IgE works, and that's quite an interesting finding in terms of the role of IgE in nasal polyps. The activation of mast cells and basophils, as we know that from allergies, does play a role. But of course, this effect is not yet comparable with what we see with dupilumab. And finally, of course, we concentrated a long time on eosinophils and counted eosinophils in the blood and in the polyp. Yes, we can also approach the eosinophils. This is a study with mepolizumab, the SYNAPSE study, which actually is an anti-interleukin-5 monoclonal antibody, and also use anti-interleukin-5 receptor alpha antibodies. And we see here that there is a decrease of the total endoscopic score. But this decrease is over 52 weeks, minus 0.73. In other words, it does not compare one-to-one with what we saw with dupilumab. It's more in the range of what we saw with omalizumab. And of course, you have patients responding very greatly to it. That's quite interesting. So there's a point improvement of these patients here, for example, of more than 5. And that is, of course, what we want if there's a polyp score of 5 or 6 in the beginning. But it's very hard to predict these patients who respond better than average to a certain of these biologics. What we can say, and I said that different biologics have a different responder rate from 40 to nearly 80, 85%, and then they have a different delta. That means the polyp score reduction, and with that, the symptom reduction is differently strong with the different biologics. So finally, of course, we can compare some of these biologics, not head-to-head, but indirect treatment comparison, so to speak, and we see that some biologics seem to be superior than others. And at the moment, I would, put my money on dupilumab. If I were the patient, that's what I would like to do, specifically because you have a quite fast reaction, 4 to 8 weeks, and you have a good activity on the smell in terms of the UPSID score, which is I think, important function of the nose. So where do we put this? Where do we situate these biologics? Of course, not to prevent topical steroids. That's always the first thing. Topical glucocorticosteroid treatment with or without oral steroids, maybe doxycycline. We have reported about that as an adjuvant. When that is not working, of course, you can consider surgery. And the point is here, what kind of surgery? If there is hint for type 2, there's proof of type 2, either in the peripheral eosinophils, in the former surgery, a specimen in the IgE type 2 immune parameters, then of course I would really do rather an extended surgery, which I call reboot, or a biologic treatment, more extended surgery than non-extended surgery, or optimal complete surgery, and or biologics. And what the most, in terms of the patient's profit, what the most positive way would be is, the most logic way is to start with a biologic, see what it does. You have to see that it works in this patient. Otherwise, there's no reason to give it for 5 years, not knowing that the patient is a responder to this biologic. So it works within half a year latest, let's say 6 months. And there is still some polyp load, which you would like to remove by surgery and still continue with the biologic afterwards. That is something that will get most of these patients under this regime symptom-free or low-symptom patients for a very, very long time. And that's what we actually propose nowadays. Thank you so much for your attention.
Thanks very much for your review of current situation with biologics.